I'm Dr. Allan Perel, and this is Conversations in Medicine. Hi, I'm Dr. Allan Perel, and this is Conversations in Medicine, a program devoted to bringing cutting-edge medical topics to the Staten Island and tri-state community. Today's program is What You Need to Know About Surgery. I have two wonderful guests. I want to thank you both for being here. Dr. Helen Kay, who's an attending surgeon and director of surgical quality at Richmond University Medical Center. Thank you for coming.
Thank you.
And Dr. Lauren Harris, chairman of the Department of Surgery at Richmond University Medical Center on Staten Island. Thank you for coming.
Thank you.
We're going to talk about surgery tonight, and we have two wonderful surgeons here, and we're going to try to get some ideas about the process of surgery and what patients and families need to know about surgery. So tell me a little bit about hospital surgery. So Dr. Harris, you're chairman of the department.
Right.
Tell me a little bit about your role in surgeries done at Richmond University Medical Center and what Dr. Kay's role is.
Well, I mean, my role is I'm the administrator for the department. I oversee all the surgeons and all of the surgery, actually, other than obstetrics and gynecology done at the hospital in terms of the actual functioning of the operating room, whether certain cases should be done as inpatients, outpatients. I deal with the nursing aspects, the administrative aspects, as well as the preoperative and the postoperative care settings for those patients.
So, and Dr. Kay, you're the head of surgical quality. Is that a new position, or is that a position that's unique to Richmond University?
It's not a new position. Many decades ago, we did not have that position, but it is not a new position necessarily to hospitals or Richmond University Medical Center. It was originally created to make sure that we have good quality surgery for patients, improving complications and making surgery safe for patients.
What kind of issues do you look at when a family member has surgery?
Yes.
And we're going to talk about different kinds of surgery. There's elective surgery where they come in and they know they're going to have the procedure that day, and there's emergency surgery, such as someone with trauma or an emergency situation. Tell me a little bit about how the surgical department handles each and what kind of things will you look at?
So there are two different types of surgeries. When we discuss the first part of your question, things that we look at for surgical quality. We want to make sure that we address all issues that are related to surgery, from infections to complications, and how we can prevent them or improve it in the future. In regards to ambulatory surgery, these are patients that we see in the office or in clinic that we set up for elective surgery, and the trauma or emergency surgeries are the ones that come through the emergency department, and we decide at that time or soon thereafter that they need to go to surgery more urgently than elective.
So maybe give me a couple of examples, Dr. Harris. Tell me something about what would be an elective surgical procedure.
Well, I mean, most of what I do is elective surgery, lung cancers, paraesophageal hernias, mediastinal masses in the middle of the chest. Those are mostly sent to me on an elective basis and operated on as an elective basis, on an elective basis. Emergency surgeries, the classic is the gunshot wound that we see in the trauma bay in our hospital. Patients are shot in the abdomen. those are generally taken right to the operating room for the most part. So patients who have large aneurysms that are either threatening to rupture or have ruptured, we have fixed several of those. Actually, since I've been there over the last year, we had 3 ruptured abdominal aortic aneurysms, all of whom survived. So, which is I thought was an amazing feat for any hospital.
So tell me, we haven't even made your talked about your subspecialties or your actually what you do during the day other than your administrative title. So Dr. Harris, I know you're a thoracic surgeon.
Right.
So maybe tell us a little bit about what thoracic surgeons do.
Thoracic surgeons pretty much do everything between the neck and the diaphragm, and other than heart surgery. Now, when you train as a thoracic surgeon, you also do heart surgery, meaning coronary bypass valves, other types of cardiac procedures. But I don't do those. Those are the specialty is kind of divided into cardiac and non-cardiac, and I do non-cardiac, which for the most part has to do with cancer, whether it's esophageal cancer, mostly lung cancer, but other more unusual tumors in the chest.
And Dr. Kay, what's your subspecialty of surgery?
I do general surgery, but I do specialize in laparoscopic and robotic surgery, so minimally invasive surgery.
Tell us a little bit about minimally invasive surgery. We've heard so much about it.
Yes.
So tell us, people are always so interested in cutting edge type things. You know, the word robotic, comes up with all these interesting things when you think about movies and all kinds of space-like things.
Yes.
So tell us take the mystery out of it. What's robotic surgery?
Robotic surgery is actually laparoscopic surgery. It's a form of minimally invasive surgery. We do the same small incisions, long instruments, and a camera that we use for laparoscopic surgery. What the robot allows us to do, however, is gives us more control over the different aspects of laparoscopic surgery. For example, laparoscopic surgery, they're straight sticks. So sometimes it's hard to reach certain areas, whereas the robot will allow us to have more wrist action. So it emulates open surgery and makes some aspects of the surgery technically easier.
Now, I know you have extensive training in that. How many years of training do you need to be
Yes.
a laparoscopic?
So you have to go through general surgery residency first, and that's 5 years. And then I personally did 1 extra year of a minimally invasive surgery fellowship where I trained in advanced laparoscopic and robotic techniques. And that's where I got my extra training and certification to do robotic surgery.
As a physician who does not do surgery, sometimes we see people doing robotic surgery. It almost looks like video games.
Yes.
And tell me, are you good at video games?
Well, you know what? When I was younger, I was very good at video games. But over the years, I haven't had the opportunity to play video games. It's definitely, you do require hand-eye coordination. So I think if studies have shown that there is a correlation with those people who play video games and their hand-eye coordination for robotic surgery.
So a lot of the younger generation, my kids who are 18, basically because of their wonderful talents in doing that, maybe there's a future in it.
There's a possibility.
Thanks. What I'd like to do is go through the steps of someone who gets elective surgery. Clearly, if someone needs an emergency surgery, things are going very rapidly. And I know at the hospital, and I'm part of Richmond University Medical Center in the neurology department, there's a wonderful trauma surgeon, there's a wonderful department in the emergency room staff to handle that. But with the elective surgery, a lot of our people out here, our audience, are thinking to themselves, what do they know? What goes on? In the old days, interestingly enough, people used to go to the hospital 2 days before the surgery. And I'm not sure what they did for those 2 days, but I remember family members going in on a Sunday night for a Tuesday morning procedure, and they would all be looked at and get, there's some preoperative testing. Now, because of different reasons, and again, cost and a lot of other things, a lot of people come in that morning for a procedure that day. So tell me, how do we set up, how is surgery set up for elective procedures? What kind of things do we have to do? And maybe even start with what goes on before the surgery.
Well, I know when I see a patient in my office, when we have mutually decided that surgery is the best course for that particular patient, I discuss with them something called informed consent. What that means is that I have discussed with the patient and maybe the family, if they're involved as well, what exactly is involved in the procedure itself, what expectations and what things we may encounter in the operation and how we would deal with it then. Also included in that is why we do the surgery, the benefit for doing the surgery, as well as the risks, possible complications and adverse reactions. That's the point of having an informed consent. The patient is now has the knowledge of everything involved with the surgery and why it would be more of a benefit than a risk.
So the consent is important. Of course, everyone needs to know what's going to happen to them. But let's really go back even to the point where something needs to be taken out, whether it's a gallbladder or something. Dr. Harris takes care of chest abnormalities, lung lesions. What preoperative things is needed? And I know it's different for different procedures. Maybe give us a little idea. And what does the primary care physician, what does the family have to do with it? What does the patient have to do with it? And again, it's a lot of questions. We'll break it down. In a sense, what has to be done before surgery and once it's decided?
Obviously, there are a lot more aspects to thoracic surgery than a gallbladder, for example, like you said. Depending on the patient's medical conditions, we do require at times a medical or cardiac risk assessment because although we're doing the surgery, there are other aspects involved to the risk element, including anesthesia. At times we will get the primary care physician involved to assess any additional risks that the patient may have during the surgery, and then we work together to optimize that patient for surgery.
And just even not to interrupt what you were saying, but that's such a marvelous thing. In the old days, we used to call those things clearance.
Yes.
And doctors, as a neurologist, people to this day call me up and I get letters and forms to fill out for clearing a patient.
Yes.
There's no such thing as clearing a patient. Everyone has risks.
Absolutely.
Some people have high risks, some people have moderate risks, some people have low risks. And we have to mitigate, reduce the risks, and try to optimize the person. So what do you guys do in addition to the internist? And again, what type of things does the primary care physician have to do? I think you mentioned to me before, making sure that someone stops smoking, tries to stop smoking, cuts down even. I don't know if that helps. Blood sugar control, weight control. What kind of things could someone do if they have a few weeks before they're going to have a procedure?
Really be as healthy as they can, like you said. If they could cut down on smoking, that's better than not. Glucose control is extremely important in regards to surgery because high sugars in a diabetic patient actually increase the chance or the risk of infection after the surgery. So things like that, making sure that they're maintaining a healthy diet. If they have high blood pressure, maintaining that blood pressure within a normal range and taking the appropriate medication.
And Dr. Harris, is there anything someone shouldn't do before surgery?
Well, I mean, I think that, shouldn't do. It's a very good question. I've never
It's
thought
not like
about
a boxing
that
match, right? So
yeah. No, they shouldn't. They certainly shouldn't use alcohol. They shouldn't continue to smoke. Obviously, stopping smoking. They need to walk. They need to get out and do exercise, things like that, to make them more fit for this. Anything you can do to increase your fitness prior to surgery is going to help you.
So now let's talk about the surgery itself.
Yeah.
So in the operating room, there's a team, and maybe you're in the operating room. I'm not. I just watched it on television. It's like one of those concepts. I'm a physician I'm a doctor
Right.
on TV.
Right.
But tell us what goes on in the operating room. Who's part of the team, Dr. K?
It's a big team because we need a lot of support. In addition to the surgeon, we have any residents or staff they may assist the surgeon during the operation. We have the anesthesiologist who takes care of giving the patient whatever type of sedation is required for that particular surgery. And there are different types of sedation that they might provide.
So tell us, maybe start even there. What kind of anesthesia do people get?
Sure. There are different kinds, anything from general anesthesia, which will put the patient completely to sleep. For laparoscopic surgery, for example, the patient needs to have muscle relaxants and paralytics on board so that we can fill whatever space that we're working in, whether it's the abdomen or the chest, with air so that we can perform our surgery. And then it can be anything in between, is a spinal or regional anesthesia, which may provide anesthesia to one particular location that will allow part of the body to be anesthetized for that particular surgery. And then something as simple as local anesthetic, which is just an anesthetic to that one particular area that we're working in.
So tell me, how do you decide what kind of anesthesia to use? I mean, I'm sure the anesthesiologist would like to be here for that, and we might have him or her on a different show. But how do you decide? Does the anesthesiologist decide? Is it a joint decision?
Well, I think the answer to your question is yes. I mean, it's always a joint decision, but the surgeon is the one who knows the procedure and in general is going to decide, depending on the type of procedure, what type of anesthesia is best for that patient. And of course, you speak about it with the anesthesiologist. The anesthesiologist will say, what is your plan? And you go over the case with the anesthesiologist and make sure that everybody's on the same page. So for the most part, yeah, it's a team decision, but the surgeon, before he shows up in the operating room, knows what he's going to do.
So tell me again, we're back in the operating room.
Yeah.
So we have the anesthesiologist, we have the surgeon, we might have people who are assisting other physicians, and I know we're at a teaching hospital, so there are residents, nurses.
Yes, nurses are very important support staff in the operating room. We have nurses and surgical techs that are also scrubbed in the surgery, therefore they're sterile, and they help us with instrumentation during the surgery. And then we also have nurses that are not a sterile part of the surgery, but help us maintain fluidity in the room. If there's something that we don't have right then and there, they can go get it for us.
Yeah.
Who does the surgery? Is it done by attending staff, meaning senior doctors? Do the residents do a lot of the surgery? Who's actually doing the operation? And because many of us out here have always had this thought, is there somebody coming in and doing some of the procedure who might not be well trained? And your capacity as chairman of the department, head of surgical quality, clearly quality is involved with who's doing the actual procedure. How does the patient know who's doing it? Do they ask you? And who actually, at this hospital, the hospital you guys have worked at, does the surgery?
The surgeon does the surgery.
Okay.
It is a teaching institution, so we, like you said, we do have residents, and they are in training to one day become the surgeon. So little by little, they'll help assist in the surgery and do a little bit more as they progress in their training. But patients should feel comfortable knowing that the surgeon is actually doing the operation.
And that's important to know. And that helps with quality, outcomes, and things like that. And I think, as you mentioned before, the amount of years of training that it takes to become a specialized surgeon, a general surgeon, and then any subspecialty is really a vast number of years. And in those years, the residents, the junior doctors who are in the hospital really do have a tremendous input in what's going on. So surgery is completed. Everybody did well. Now, tell me about postoperative care. Does it matter? Does it matter really? Does it matter where you are? Does it matter who your team is? Does everyone who has a good surgical outcome in the operating room walk out and do great? Or how do you make that? How do you make the next step? That's basically the team that you guys are setting up. So tell everybody out there, once you leave the operating room, does the surgeon go out to lunch? What do you guys do?
Hardly, yeah. No. I think that, there are several phases. Well, there's really 3 phases to every operation. The preoperative preparation, good history, good physical, good workup, making sure that you've seen all the films, you know this patient, you've seen all the labs, make sure all the T's are crossed and the I's are dotted. Then the intraoperative performance, the team aspect, anesthesia, nursing, your assistants, having a plan when you go in, knowing your anatomy, all that is so critical. And then of course the postoperative care. And postoperative care is absolutely key. Where you put the patient, depending on the operation and the patient's comorbidities, where
You
that
mean
patient,
comorbidities if someone's diabetic, if
Right.
someone has high
Yes.
blood pressure,
Right.
things like that.
multiple studies have shown that good glucose control, all those things really make a difference in terms of surgical wound infections and also surgical outcomes. Making sure that the patient is in the right place, getting good nursing care, what we call pulmonary toilet, meaning deep breathing, coughing, clearing secretions, all that stuff is critical. You can't just do the operation and say, okay, he's fine now and walk away. That doesn't work.
Yeah.
Doesn't work.
And the family is important in that as well. So you want to make sure that you have a good conversation. Well, the surgeon, we want to make sure we have a good conversation with the patient and family in regards to the expectations that they should have before, during, and after the surgery. And the family is very important in making sure that the patient adheres to our postoperative instructions in order to prevent any infections postoperatively or recurrence of, let's say, a hernia that we just fixed.
So things have changed over the years postoperatively, after the surgery. So I'll give you the medical aspect as being on the medical side. When someone had a heart attack in the 1970s or 80s, they were put in a dark room in the corner of the hospital and told to rest.
Oh.
Now they're mobilized within hours and going up. When hip replacements first came out, people were, again, very much jostled, kept in a quiet area for a little bit. Now, tell us a little bit about what you guys do with patients. And again, they're generalities. What do you do with patients to get them mobilized, to get them into a chair, to get them, as you mentioned, with regard to deep breathing?
Yeah.
In order to prevent pneumonia, prevent bed sores, all kinds of terrible things that can happen relatively quickly, even clots in their legs.
Absolutely.
What kind of things do you do to mobilize patients quickly, and who do you mobilize and who don't you?
Well, I think for most of our patients, certainly Helen's patients, my patients, these are general surgical or even general thoracic surgical patients. Most of them are up, walking, out of bed the next day, if not the same day.
Yes.
And the whole idea, back in the day when I was training, and you and I were probably same vintage, many of these patients had NG tubes for days and were bed bound.
Tell us an NG tube.
Yeah.
What is that?
No, I'm sorry. It's a nasogastric tube. It's a horrible device that goes through your nose and into your stomach to drain the stomach. Now, some patients need them, but we've stopped using them for the most part in many of our patients. Early mobilization, pain control, and the minimally invasive approach to surgery has really made amazing advancements in all of that.
Tell me about catheters. So we talked about
Yeah.
NG tubes, the
Yes.
tube that goes in your nose. How do we try to use less of them, or what do we do to try to prevent infection?
Yes, part of the surgical quality care, we want to make sure that we decrease possibilities of infection. And in doing that, we decrease the use of catheters, whether they be urinary catheters named Foley's, or any type of catheters, large bore catheters that we put in veins to give medications, for example. that's actually one aspect of the Surgical Care Improvement Project, or also known as SCIP measures. It's a nationwide protocol that's been put into place to decrease complications, and one major aspect of it is to decrease infections by removing catheters within a certain period of time after surgery, for example.
So a catheter, it basically is something that brings the outside world into your domain, into yourself.
Yes.
And we don't want anything from the outside world being inside. That's
Exactly.
that's why we're sort of sealed up the way we are. Tell us a little bit about any new technologies. And maybe let me take a step back. People are always concerned, you go from, they do multiple operations in a room, 1, 2, 3 in a day. What happens after the first surgery? How is that room made sterile or clean enough for the next patient to come in? What do we do to prevent problems?
Every room is thoroughly cleaned by the very important cleaning staff and sterilized. Every surface, the floor, everything that is, including the bed in which the patients are lying on, to make sure that we decrease infection.
And that's so important. I mean, that's clearly. So let me ask you, with regard to, we have a few minutes left, new technologies in surgery. And what kind of things, say at your hospital, my hospital, our hospital, Richmond University, what kind of things are going on right now, whether it's to reduce infection, more family intervention, interaction intervention, newer techniques, what kind of things are going on that people sometimes hear about at Manhattan institutions that is being done in the community, whether it's Richmond University or whether other hospitals on Staten Island or all over through the outer boroughs or anywhere in suburbia or even rural areas. So we have a little bit of time. What kind of things are going on? What's the cutting edge thing in surgery going on?
Well, I mean, I think we've talked about it already. I mean, the real cutting edge is the robotics. I mean, doing things through smaller incisions to get patients from the operating room back home, back to their lifestyle. Our goal is to fix whatever the issues are and get the patients out of the hospital.
And most people can get out of the hospital in a relatively short period of time if it's not a complicated.
Now, our average length of stay at Richmond University in the surgery department is about 4 days, and that includes everybody. So a lot of people are going home the next day or not even staying in the hospital at all.
People talk about lasers with regard to treatment, and tell me, is that part of it? I mean, clearly doing surgery involves a cut somewhere. I mean, that's sort of the definition of it.
Yeah.
Otherwise, it would be just what I'm doing, rubbing their arm. Something's got to be a little different. So tell me a little bit about lasers. Is there any part that you guys do with all these newfangled things?
Lasers aren't really part of the general surgery world at this point, and definitely not with the minimally invasive. So it's definitely not part of what I do.
Yeah.
Appreciate it. And I want to say thank you to you guys. I think it was marvelous to hear a little bit about what goes on in the operating room. I think we've heard at different times when we've spoken about whether the loud music, soft music, whatever the surgeon likes. We try to make the environment as good for the patient and the surgeon. And in order for us to get a good outcome and people to do well, and I think this new specialty, there's always been chairmen of departments, but having a specialty of quality, surgical quality, I think is something that's very unique and something very, very nice. A lot of big hospitals, as you said, have it. And the idea that we're able to give patients the best care both before surgery, during surgery, and after surgery really speaks volumes. So thank you so much.
Great, thank
Thank you.
you.
Good night.